Febrile neutropenia is one of the most common life-threatening complications of cancer therapy. It's an oncological emergency that must be rapidly treated, but often people struggle with its exact definition and miss some cardinal rules when assessing and managing it. Wait to the end because I've got a really good rhyme to help you remember this content and tie it all together at the end. It's broadly defined as a temperature of 38 degrees with a low neutrophil count of less than 0.5 or under 1 if you expect that it's going to decline. But there are two really important caveats with this definition. Firstly, if you suspect the patient is probably neutropenic, based on a recent history of chemotherapy, don't bother to wait for blood counts to start antibiotics. Secondly, because a fever may not be present due to the neutropenia in the first place, you should still consider there's an infection if the patient is unwell. Some important risk factors include hematological malignancies, age above 60, concurrent radiotherapy, and previous episodes of febrile neutropenia. Now, it's extremely important to characterize the infection. We want to know what it is and where it's coming from. And this is where people make their first serious mistake. You must collect at least 2 sets of cultures, at least one from each central venous access device, and at least 1 set of cultures peripherally. If they don't have something like a portacath, you should just collect 2 sets of cultures peripherally using good aseptic technique. Other blood tests to consider include a full blood count, a UEC, LFTs, a CRP, and a VBG just to check the lactate quickly. Finally, you should always consider other investigations to find the source of infection, including a urine dipstick, swabs from any focal suspicious lesions, and a chest x-ray. Let's move on to management with this quick disclaimer. The choice of antimicrobials for treatment should be based on your local protocols or infectious diseases advice. You shouldn't base your management of patients based off my YouTube channel, but this is a good place to start just to understand the background of febrile neutropenia. It requires the rapid initiation of broad-spectrum antimicrobials, at least within 1 hour of the patient presenting to medical care. In patients without septic shock and not requiring intensive care support, initial therapy often includes the use of IV piperacillin and tazobactam, which is often described as PIP-Taz. If the patient has features of sepsis, you should step up your management accordingly. Source control is really important to consider. IV lines and central venous catheter-related infections are common in patients with neutropenic fever. Consequently, you should promptly remove them if you consider that they might be a potential source. Early antifungal and antiviral therapy may be required for patients suspected to have opportunistic infections, especially things like Candida albicans. Finally, management with antimicrobials needs to be monitored and regularly evaluated. Now, to remember all of this, I've got a mnemonic to help you remember the definition and some key parts of assessment and management. The poem of febrile neutropenia goes a little like this. 0.5 and 38, there's no time to wait. Take cultures twice and consider PIP-Taz and spice. Now, the first 2 lines tell us the definition of febrile neutropenia and that there's no time to wait for management. The second 2 lines tells us to take appropriate cultures and contemplate starting PIP-Taz. SPICE is an acronym for other things that you should consider, including if the patient has features of sepsis, if there is a port infection or an IV line infection. You might also have to give antifungals to treat something like Candida. Finally, E stands for escalate, and this is because you should always reach out to a senior if you're worried a patient has febrile neutropenia. Thanks so much for watching Townsend Teachings. Don't forget to like, comment, and subscribe.